Good morning and welcome to all. I'm Dr. Nick Carleton and I have the privilege of serving as the Scientific Director for the Canadian Institute for Public Safety Research and Treatment. I want to welcome all of you to PSP Session A. I'm very excited about all of our research presentations this morning and this afternoon. I also want to underscore again my gratitude to CIMVHR for allowing us to be part of their fantastic forum again this year and congratulate all of the researchers on their terrific successes. A couple of quick housekeeping notes. If you're having issues with your stream quality, please click on the click here to switch to the alternative stream button below the video player. I'd like to introduce our first presenter, Dr. Greg Anderson, who's the Dean of the Faculty of Science at Thompson Rivers University. Dr. Anderson is an award-winning educator and scientist who focuses heavily on applied knowledge translation. He's also currently serving as a leader on the CIPSCERT Academic Research and Clinical Network Advisory Committee. Welcome, Dr. Anderson.
Hello, I'm Dr. Greg Anderson, and I'm presenting our paper today on occupational, personal, and psychological impact of COVID-19 on public safety personnel. I'd like to thank my co-authors, Paula Denoda, Robin Shields, Dr. Nick Carleton, Heidi Cram, and Diane Grohl. I am the faculty presenter. We have no commercial interests to declare. This research received in-kind support from all of our institutions. Qualtrics was used on the server at Queen's University. We had no bias to mitigate at this point. Our learning objectives were pretty simple. We wanted to investigate the impact of COVID-19 on the mental health and well-being of firefighters, paramedics, and public safety communicators, 911 operators, dispatchers, those people in the province of British Columbia. And we were subsequent to that wanting to look at how that changed through phases of public health order. So in the first phase of the public health order, we had social distancing and wearing of masks. As the public health orders became more stringent, the size of gatherings started to become smaller. We closed non-essential services. And in the end, we had travel restrictions, groups no longer bigger than 2, no public restaurants or those types of non-essential services going on. So as we moved through those series of public health orders and they became more stringent, we wanted to look at whether that also had an impact on the mental health and well-being of our practitioners. In general, we would expect that PSP, who are required to perform their duties during the pandemic and escalating cases and virus spread and potential contact with the virus, you would expect them to have increased concerns. So there's concern over exposure to the clients that they're working with. They wondered what public or what personal protective equipment was required, what worked, what didn't work, what was most effective, what needed to be worn. They were starting to work long hours. Some of the staff were being taken out of rotation because of mandatory quarantines. They became isolated from their family and friends because if they thought they could get potential exposures, they may not be social. They may have actually, lived in an alternative space, that type of thing, to try and manage that. So the family responsibilities became a little bit more difficult, where we had a practitioner who had very long hours, working extra hours, needing to isolate and not be involved in the family activities. The other parts that can come in, I mean, how were they being treated? So if you're working in the public and you're working with people with COVID, people expect that you might be carrying COVID and be a potential risk for them. So there was some discrimination or bias against them in the social settings. The early work in phase 1 of the COVID response was done in nursing in British Columbia. And what they found was that moderate to severe anxiety and depression increased during COVID. And so there were higher levels of poor mental health and generally an increase in the negative treatment inside the workplace. So we would expect the same to occur in public safety professionals that have high exposure rates to clients that potentially had COVID. So we collected some survey data at the baseline, which was provided by Dr. Nick Carlton. And then we had phase 1 and one other phase, depending when they did the follow-up. So we have data from all of the practitioners at baseline and at phase 1 of the public health order. And then we have one other point in that spectrum. We used descriptive statistics and looked at the symptoms. We compared them across phases. We used an ANOVA and linear regression analysis. And we also had an open text, 2 open-ended questions that asked about changes in work and home life that we analyzed using thematic content analysis. The groups that we had access to were public safety communicators, firefighters, and paramedics in the province of British Columbia. We had 48 public safety communicators, 123 firefighters, and 245 paramedics participate. They were typically mid-career professionals. What we found was that looking at pre-post, so this is baseline data to any point during COVID, was that the depression was higher in firefighters and paramedics and approached significance with a small number in public safety communicators. So the incidence of moderate to severe symptoms and self-reported symptoms in these occupations was significantly higher in firefighters and paramedics. There was no significant difference in anxiety, but there was in social anxiety. As expected, we didn't expect to see the immediate increase in post-traumatic stress because that is the long-term effect of trauma and stress. So if we looked at depression as an example, and the orange bars or red, depending on your screen, this is the scores after COVID, whereas these are our pre-COVID scores. So we can see that in all the occupations that the self-reported symptoms for moderate to severe depression went up in these occupations. The other part here shows that in phase 1, where we just had social distancing and masking, the increase was less than in full lockdown. And that we had a trend of, as the phases went from phase 1 to phase 4 of public health orders, for the symptoms to get worse. So the impact of phase on public health, the impact of phase of public health order. So we used firefighters as the baseline, and then we compared the paramedics and the safety communicators to those that population. And paramedics had the most dramatic increase in scores related to depression. Both public safety communicators and paramedics had a more dramatic increase in scores related to general anxiety. And there was an increase in social anxiety in both public safety communicators and paramedics. So the phase of the response had an impact, a significant impact on the scores for these particular professions. The qualitative results, 2 major themes here. The job changed. The job wasn't what they were doing pre-COVID. COVID changed the nature of their job and the occupational health protocols. An example was losing purpose and loss of job satisfaction. Nothing has stayed the same. There was also a personal cost. COVID has introduced new dimensions into the home and work-life balance that can be problematic. Limit recovery time and shift household activities. And an example there was, it has put a great strain on my personal life. I feel I must basically quarantine due to my line of work. I don't want to put friends and family at risk that are outside of my house since I feel like Typhoid Mary. So there isn't a lot of other data. So I really wanted to talk about what do we do in response to knowing this, that during the pandemic and during increased stringency of public health orders, there will be a greater impact on the mental health of our public safety professionals. Part of this is looking at what is good leadership during COVID. And this is really looking at communication and having effective crisis management planning and action. Communication of up-to-date information, whether what is the new public health order, those things shift rapidly. What does that do to my job? What does it do to the equipment that I have to wear? What does it, how does it impact the training that I have to do? So those types of, that type of communication is essential during this particular pandemic. And then there has to be an increased provision for the continuum of support for the staff. So this is everything from a leader that recognizes and acknowledges how they're feeling, to peer support, through to a full suite of services outside of the organization as the use of those will increase. The other piece of this is that work is one part of the COVID response, family is the other. And so as an employer, we need to recognize that their personal circumstances can change very rapidly. A child comes home with COVID, everybody's isolated, your role within the family might shift. So there was a lot of other types of stresses on the particular employees. Increased awareness. So the other thing that we could say is that a leader should recognize and address uncharacteristic behavior and performance. And really important to that is that they don't diagnose, they recognize when somebody might be in trouble, and they encourage them to seek help. So signs that people are struggling could be increased conflict, unprofessional behavior, either internal or external to the organization, lateness, frequent breaks, excessive absences, reduced quality of work, lack of participation and withdrawal from avoidance of activities. They may be confused, forget, they miss deadlines, and there may be a change in their appearance or their hygiene. These are things that might trigger a conversation with an employee to see if they're doing well. So it really comes down to leaders need to help. Recognize the impact of COVID and escalating public health orders and what that strain is on the public safety professionals. They need to look at some sort of training so that others recognize those in need, and like a peer support program. Display empathy. Make sure that they acknowledge the others, how others feel. Make sure that they can normalize some of that when appropriate, and really be a strong advocate for training and increased mental health services to help these particular people. When you recognize somebody in need, encourage the help-seeking behaviors that we all know. So in general, what we found was that there is a dramatic impact. That impact was pronounced more in depression and social anxiety than others. There was no change in post-traumatic stress disorder, but we also recognize that that's a downstream effect of having trauma and not something that is happening at the time of the incident. The other part of this is that there is going to be an increased need for mental health services within the organizations, and we should be looking at a way to deliver appropriate services to our public safety personnel at a time that's convenient, in a place that's convenient, and in a way that acknowledges their role during the pandemic. We have a list of references that you can look at. And if you have any questions, you can contact me at any time. Thank you.
Thank you to Dr. Anderson for that presentation. The results are very timely and I think help to underscore the compounding challenges facing our public safety personnel throughout the pandemic. I'm now very happy to introduce Dr. Diane Grohl, who's graciously agreed to stand in for Dr. Anderson, who was unavailable to answer questions this morning. She's an award-winning academic who is also the Assistant Scientific Director with the Canadian Institute for Military and Veteran Health Research. She's a registered nurse specializing in psychiatry, and she's been engaged in population health research for over 25 years, focusing on mental health, operational stress injuries, post-traumatic stress disorder, all in the Canadian Forces, veterans, and public safety personnel. Dr. Grohl, thank you very much for joining us this morning, and I'm very happy to start with our first question if you're ready.
Thank you. Yes, I am. And I apologize. It sounds like our people have just come back from wherever they were and have started drilling on our walls.
No worries. This is part of the challenge of Zoom everything still as we're moving through the pandemic. So, Dr. Grohl, you and your team were able to show that there are large changes pre versus post-COVID in the PHQ-9 and SIPs in the firefighters and the paramedics. Do you think this is explained by the verbal descriptions given later, or do you think there's more to these numbers?
Right. Well, what we're looking at, so we're kind of looking at two separate things. The verbal explanations, they are the words that people would give to describe how they feel at a certain time. The numbers that were given during the questionnaire part of it go over the period of time specific. So they are sort of different. We are asking for people's responses at the second that we ask them, or at the minute that we ask them. So while I think they're definitely related, so people said that they feel very stressed, they feel like typhoid Mary, that kind of thing. I think that went on through the phases that we looked at. I don't think that they're exactly the same. I think it really depends on when the questions were asked of the people. But I think that the verbal parts are very interesting, and we do have a lot more of them, and they really do give a fairly good description of how people felt when they were asked about how things were going, whereas the questionnaires with the results were more, we asked the 200, or there ended up being like the 500 people, and they're much more specific to the specific questions, to the specific times, whereas the other ones weren't.
Terrific, thank you. We have more questions coming in from our participants this morning, which is terrific. Our next question is, did the qualitative data reveal anything about the public pressures that are associated with anti-vaxxers and protests?
Okay, so this is from a while ago. I don't think so. I think we didn't ask anything about the anti-vaxxers, because back when we did this, again, it was the beginning of the section. At the beginning of the pandemic, there wasn't a lot of information about anti-vaxxers. Anti-vaxxers, as far as I know, this is based in Kingston alone, really, have come to the forefront more now that vaccination is up. So back in the time when we did the study, there wasn't a lot of, there weren't any solid vaccinations that you could have. Like we're all still waiting to get vaccinated. So I don't think there was a lot of anti-vax stuff.
Terrific. And do you think that is there any data that you can speak to that might suggest how the PSP might be experiencing those pressures associated with the anti-vaxxers and the protests that are going on right now, based on previous research that PSP may have regarding social supports from their communities?
Right. Again, we don't have any information based on anti-vaccination. We didn't ask that question. The questions weren't even sort of thought about at the time because there were no vaccinations to be had. I personally can't say how that would relate now to what we have. I personally haven't done any research looking at how people feel about the vaccinations or not having vaccinations available. So unfortunately, I really can't answer that question.
Terrific. All right. Well, thank you very much for your time this morning, Dr. Rolla. I've been told that's all the time we have for Q&A this morning. I really appreciate you stepping in for Dr. Anderson. Thank you for your research and your work and your contributions to CIMVHR and CIPSRT and so many other organizations. Thank you very much.
Thank you very much. Okay, bye.
And now I think we're moving to our next presentation for this morning, which is Dr. Rachel Plouffe. Dr. Plouffe is an award-winning postdoctoral associate with the Macdonald Franklin OSI Research Centre and Western University in London, Canada. Dr. Plouffe completed her PhD in the psychology program at Western University in 2020. Broadly speaking, her research interests reflect psychometrics, as well as identifying contributing factors and outcomes associated with moral distress and moral injury. Please join me in welcoming Dr. Plouffe.
Hi, everyone. Thank you so much for joining today. My name is Rachel Plouffe. I'm currently a postdoctoral associate with the Macdonald Franklin OSI Research Center and through the Department of Psychiatry at Western University. And today I'm going to be presenting on impacts of morally distressing experiences on the mental health of Canadian healthcare workers during the COVID-19 pandemic. So we have no relationships with commercial interests to report. And our project was funded through support of the Macdonald Franklin OSI Research Center by the St. Joseph's Healthcare Foundation and through a partnership with the Center of Excellence for PTSD. We have no potential for conflicts of interest to report, and we don't anticipate any potential for bias. By the end of this talk, you should be able to identify risk factors and outcomes that are significantly associated with moral distress in healthcare workers during the COVID-19 pandemic, as well as summarizing the impact of the COVID-19 pandemic on healthcare workers' organizational and psychological well-being. And finally, you should be able to describe the frequency and levels of distress associated with exposure to morally distressing events in a large sample of healthcare workers across Canada. And before I get started, I would just like to thank my co-authors and my team, both internally and externally, for their expertise and collaboration on this project. And it's currently in press in the European Journal of Psychotraumatology. So since the start of the pandemic, COVID-19 has caused over 4.5 million deaths worldwide. And in addition to the high levels of morbidity and mortality, the pandemic has since resulted in devastating impacts on individuals' psychological well-being. So people might experience a range of events, including risk of infection to themselves or to their family members, job loss, school closures or new distancing protocols, lockdowns, and physical and emotional isolation. But among those who are most vulnerable to the psychological effects associated with the pandemic are healthcare workers. Healthcare workers are currently facing unprecedented situations that involve life-altering moral and ethical decisions, including, for example, rationing of limited healthcare resources to patients who are equally in need, and even the possibility of ending life for some patients to allocate resources to those with fewer comorbidities. And these are just a couple of examples. This results in detrimental consequences, including reductions in the quality of patient care, as well as increases in healthcare worker moral distress. So moral distress was first introduced by Jamieson in 1993 in nursing research, and it's defined as individuals being constrained to behave in a way that they perceive as morally or ethically inappropriate. And as such, they're unable to act in accordance with their core values, and they're thus forced to compromise their typical standard of care. And an example of a morally distressing event could be when one is required to care for more patients than they can safely care for example. So some outcomes associated with moral distress in healthcare workers include anxiety, depression, secondary traumatic stress, burnout, low job satisfaction, and intent to leave one's position. So to date, associations between a variety of workplace experiences and moral distress have not been empirically tested in a large sample of Canadian healthcare workers during the pandemic. And the impact of moral distress on healthcare workers' mental health has also not been empirically examined in the context of COVID-19. So our goal was to test these associations. So our first objective was to evaluate the impact of organizational variables on the frequency and severity of moral distress during the COVID-19 pandemic within a Canadian healthcare worker sample. And these organizational variables included, first, adequacy of resources. So this would include PPE, ventilators, staff availability, medication, and information from management. The second organizational variable was COVID-19 risk perception. So how strong does one feel their own risk is of contracting COVID-19 or giving it to their family, for example. The third was positive work-life impact. So do they feel like their work hours are manageable? Do they feel supported at work? Do they have social support? And are their decisions backed up at work as well? And the next one is leadership. So this is at both the organizational and the managerial level. And then we finally have ethical work environment. So how ethical do they perceive their workplace to be? Our second objective was to evaluate the effect of the frequency and severity of moral distress during the pandemic on symptoms of psychiatric disorders in healthcare workers. And these included anxiety, depression, burnout, and symptoms of post-traumatic stress disorder. So we recruited 1,362 English and French-speaking healthcare workers. They had to be at least 18 years of age and employed as a healthcare worker in Canada between the start of the pandemic and the baseline end date. They were recruited between June 26, 2020 and December 29, 2020. So December 2020 was that baseline end date that I referred to. And they were directed to complete a series of online questionnaires via Research Electronic Data Capture, or REDCap is what it's known as. They had a choice to complete either a long or short form of the study, depending on their availability. And we analyzed their baseline data. So we are collecting longitudinal data every 3 months for various follow-ups, but here it's just the baseline that was analyzed. So we collected a series of demographic information. For moral distress, we had the measure of moral distress for healthcare professionals. We had the expanded well-being index for burnout. The pandemic experiences and perceptions survey measured those organizational variables that I mentioned previously. The ethics environment questionnaire to determine whether their work environment was ethical. The patient health questionnaire for depression, the GAD-7 for anxiety, and then finally the PTSD checklist for the DSM-5 to measure PTSD symptoms. So the majority of our sample, as you can see here, ranged in age from about 26 to 60, and an overwhelming number of our participants were women. So this looks very skewed, 974 women. However, most of our sample were nurses, so these numbers do make sense when you look at their occupations. The majority of them were also married, and most were from Ontario. We had 32% from Ontario, followed by Alberta, and then British Columbia, but we did have representation across all of the provinces. Most of them were involved with direct client and patient care and worked in a hospital or community center setting. Our top 5 occupations of our sample were nursing, community health and personal support workers, physicians, paramedics, and social workers, although there were several other occupations that represented a smaller number of individuals. And 792 healthcare workers were directly involved in clinical activities that were related to COVID in the month preceding participation. So our results here, before I get into these, I just want to mention that the most frequently reported morally distressing event was witnessing low quality of patient care due to poor team communication. And the most distressing event that was reported was being required to care for more patients than one can safely care for during the pandemic. So if you look at the structural equation model here, we have our organizational variables. So the first one here on the left is resource adequacy. Underneath that, we have risk perceptions of COVID-19. And then we have work-life impact, or basically that support at work variable. And then finally, the bottom circle represents the EEQ, which is ethical work environment. And what we want to focus on here are the lines connecting the organizational variables to MMD on the right, which is moral distress. So we're looking at whether these organizational variables predict levels of moral distress. These curved lines here represent the correlations between the organizational variables, but we're going to focus less on that for the purpose of this. So here we can see that if you have higher levels of resource adequacy, work-life support, and ethical work environment, you're actually going to experience lower levels of moral distress, which is what we would hypothesize. On the other hand, you can see that when you have higher levels of risk perceptions for COVID-19, so you think you have a high chance of catching it or passing it along to a family member, you're going to experience more moral distress. So this is essentially what we hypothesized. So you'll notice that leadership that I mentioned earlier is not included in this model, and that's because errors across the items wanted to correlate, which indicates that there's some variance in common between the items that had nothing to do with leadership. Usually this is due to something like item wording, and it can indicate that the measure's reliability and validity should be further established before we use it in practice. So we opted not to include it in this model here. So to fulfill our second objective, we looked at whether moral distress on the right-hand side here, MMD, predicted levels of, we have burnout on the top, and then we have PHQ for depression, generalized anxiety disorder as the next one. And then finally, we have levels of PTSD on the bottom. And you can see that in each case, moral distress significantly and positively predicted levels of all of these outcomes. So burnout, PTSD, depression, and anxiety. So when healthcare workers engage in activities that they perceive to be morally or ethically conflicting, individuals may perceive themselves as failing to uphold their core values and roles as advocates and caregivers to patients. And this can in turn lead to feelings and symptoms of anxiety, PTSD, burnout, and depression. So our findings highlight the need for healthcare worker organizations to implement strategies designed to prevent long-term moral and psychological distress in the workplace. Specifically, our results indicated that ensuring the availability of adequate resources like PPE, ventilators, medications, and staffing numbers, reducing healthcare worker risk of contracting COVID-19, providing organizational support regarding their decisions and individual priorities, and upholding ethical considerations are crucial to reducing the severity of moral distress in healthcare workers. So lastly, I would just like to touch on some limitations and future directions associated with our study. So as I mentioned before, our sample was predominantly women. We had very few men in our study, so it's not clear at this point whether our findings will generalize to men, although we would anticipate to see the same findings. And like I mentioned, the fact that our sample comprised mostly women does make sense given that a lot of our sample were nurses. We also need to see whether our results generalize perhaps outside of Canada, or whether our results differ depending on whether one is directly involved in patient care versus in a more administrative role, etc. So do our findings translate to different groups? Our findings were also cross-sectional in nature, so longitudinal data reflecting moral distress and well-being is needed to test certain hypotheses that may clarify causal relations. So for example, we could assess moral distress as a mediator in the association between, for example, resource adequacy and burnout. So that would require longitudinal data to look at those causal associations. And we are currently collecting longitudinal data as part of this project. Finally, it is possible that respondents who see an ad posted for a study about healthcare workers during COVID-19, they may be more likely to be experiencing some sort of moral distress and to want to have their voice heard or put it out there. So individuals who are quite happy and content during COVID and haven't experienced many organizational or personal psychological changes, they may be less likely to want to reach out and participate in something like this. So that is a possibility to keep in mind. So here are the references associated with today's talk. And thank you so much for listening and for having me today. I have links here to our website, our Twitter page, and my email address if you have any questions. Thank you very much.
Thank you very much, Dr. Plouffe, for your presentation. The results are, again, very timely, and I think really help to showcase some of the important factors that are interacting with mental health, such as moral distress and organizational environments. We have some questions from our audience, starting with an attendee asking if you can speak a little bit more to how representative your sample was of Canadian healthcare workers in terms of job and gender distributions.
Yeah, of course. Thank you so much for having me today. I'm really excited to be here. So we actually have looked at some preliminary representativeness of our baseline sample against a Canadian national database of healthcare workers. And we found that relative to the national sample, we have somewhat fewer nurses, surprisingly, because our sample was predominantly nurses. But compared to about almost 70% nurses and 14% physicians in the national sample, we had about 40% nurses and 3% physicians. So these are differences of roughly 30 and 10%. But when it comes to the other disciplines like personal support workers, paramedics, social workers, et cetera, they were actually pretty in line with the national database. And then in terms of gender distributions, female nurses, again, were somewhat underrepresented, but the other occupations were kind of on par with what we would expect for the distributions of men and women.
Terrific, thank you. That really helps to showcase how the results can probably be generalized a fair amount beyond the sample. We have a second question asking, what do you think organizations can be doing better to support healthcare workers right now?
Of course. Yeah. So based on our findings, I think it's really important that organizations and management takes a preventative approach as opposed to sort of a reactive approach to mitigating these sort of negative outcomes like burnout, PTSD symptoms, depression symptoms, et cetera. So they could provide access to psychological supports to healthcare workers and even potentially their families if possible. And encouraging communication, I think, is really important within their departments and to their management about whether when they've encountered a morally distressing event, potentially going to management and telling them that this has happened and seek that support and just be open to receiving that information and providing supports where needed, and also providing accurate information regarding, COVID protocols, number of those infected within the organization or patients, and then being transparent about where scarce medical resources are being allocated to. And then ultimately, I think setting an example for their employees and ensuring that they have time for rest, self-care, receiving the support that they need.
We have one final question for you this morning. So can you speak briefly to how you think moral distress and moral injuries might be interacting with mental health challenges among our healthcare workers and among, broadly speaking, our PSP?
Of course, yeah. So I think when one encounters a morally distressing event, depending on the individual, they may interpret it differently. So some may interpret it as extremely negative, whereas others might already have certain coping mechanisms in place where they don't feel as much distress. But I certainly feel like these types of morally distressing and morally injurious events do contribute to some distressing psychological outcomes a great deal, to, for example, depression, anxiety, and PTSD symptoms. And I think our structural equation models kind of pointed to that differences in the distress associated with these events do contribute to those outcomes quite substantially.
Terrific. Thank you very much. Well, thank you again for your presentation and your research and for joining us this morning. I appreciate it.
Excellent. Thank you so much.
Good morning, all, and welcome back. I'm very pleased to introduce our next speaker for this morning, Dr. Milis Passojovic, who is currently serving as Chief Clinical Officer at Wayfound for the Before Operational Stress Program. She's also an adjunct assistant professor at the University of Calgary, where she taught graduate and undergraduate levels of courses. She also maintains a clinical practice focused on first responders and other public safety personnel. Please join me in welcoming Dr. Passojovic for this morning's talk.
Hello, my name is Dr. Milis Passojovic. I'm a clinical psychologist and I'm the Chief Clinical Officer of the Before Operational Stress Program, or the BOSS program as we call it. And that's what I will be talking with you about today. Specifically, I'll be talking about adapting the program components and delivery modalities. Just want to take a second to acknowledge the co-authors or the co-presenters on this presentation, Dr. Megan McElhern, the creator of BOSS, Dr. Andrea Stilnicki, Dr. Amber Fletcher, and Dr. Nick Carlton, who are all part of CIMVHR, been integral in the BOSS development dissemination process. Again, I'm Dr. Milis Passojovic. Related to relationships with commercial interests, I am an employee of Wayfound Mental Health Group, Inc., for which Dr. Megan McElhern is the CEO, and she's the creator of BOSS, so relevant to disclose that, that relationship. And related to commercial support, so this program has received financial support from Wayfound Mental Health Group, Inc. in the form of the program delivery of the BOSS program. This program has not received in-kind support. And related to conflict of interest, I have received payment from Wayfound Mental Health Group, Inc. for delivering the BOSS program, as I am an employee of Wayfound Mental Health Group, Inc. And Wayfound Mental Health Group, Inc. also developed BOSS, which is a product that we discussed in this program, as I indicated. In an effort to mitigate potential bias, this presentation will be limited to the discussion of evidence without personal recommendations. The information will be presented, the information that will be presented is explicitly evidence-based rather than personal recommendations, and BOSS is independently evaluated by the researchers I mentioned at the University of Regina. At the conclusion of this activity, you'll all be able to describe feedback from BOSS participants about program components and mode of delivery. So an introduction to BOSS. What is BOSS? So BOSS is a resiliency-based program developed by Dr. Megan McElhern in 2017. So Dr. Megan McElhern has been in the public safety mental health space for a really long time and found that she was having a lot of the same conversations with her patients over and over again. And what she was hearing in her sessions was this idea of, if I would have gotten this information earlier on in my career, perhaps the trajectory of my career and my life could have been different. And so thereby came the origins of the development of BOSS, with the idea of BOSS being sort of this kind of proactive protection approach to mental health support for public safety members. So this idea of providing public safety members with the psychoeducational content in advance of their career, early on in their career, rather, so they could then recognize the potential for operational stress early on in their career and then take steps to mitigate those potential effects based off of their psychoeducational knowledge related to mitigating operational stress. So she started to develop the BOSS program sort of over time, over the course of her career. In the early phase of early phase of the program was developed in 2017. And then Dr. McElhern paired with Wounded Warriors Canada, who has been integral in the liftoff of the BOSS program. So they have provided the funding for the pilot program as well as other deliveries, even on an ongoing basis. They've been integral in the development and dissemination of BOSS, and they are the charitable arm to the BOSS program. And then BOSS was also undergoing, as I indicated earlier, independent research through CIMVHR at the University of Regina to ensure it is rooted in literature and research and not just based off of somebody's gut feeling, as we know that these resiliency programs are really, really important to make sure that they are rooted in the research and undergoing investigation as well. Scholarly investigation, I should say. And so with Dr. McElhern, Wounded Warriors Canada, and CIMVHR, the first pilot program was delivered in 2018 to a small group of Calgary firefighters. I had the privilege of co-facilitating that group. It was a condensed delivery, so it happened over a weekend. I'll get into the standard delivery shortly, but that was a condensed delivery that happened over a weekend. It occurred with resounding success. We got a lot of really positive feedback qualitatively, as well as what the early preliminary research reflected as well. And so there we had our initial BOSS liftoff. We had a second pilot group rolled out in Ontario in 2018 as well, on a group of paramedics. And since then, BOSS has taken a lot of different iterations, which I will get into shortly. So what is BOSS? BOSS is intended to be 8 psychoeducational modules on topics related to mitigating operational stress. So BOSS was originally developed to be group therapy, process-oriented, both content and process-oriented group therapy. So 2 hours per week for 8 weeks, where it's clinician facilitated and different topics related to mitigating operational stress are discussed, taught to the group members, and then clinically facilitated to ensure that the participants are making personal meaning out of the content. Up to 10 participants per group for this original delivery. And there were also 10 monthly maintenance groups. So once a month for 10 months for BOSS to be a year-long program, with the idea that the maintenance groups would be an opportunity for the participants to maintain that social connectedness, continue to talk about ways that they've been applying principles of BOSS, and identify obstacles to what they've learned, to implementing what they've learned. Since 2018, Dr. McElhern and I have personally trained 83 clinicians across Canada on delivering BOSS, and we have had in-person BOSS groups delivered in the provinces of Alberta, Ontario, and Saskatchewan. Of course, because BOSS has been undergoing independent research, we have some promising results research-wise. We found some CIMVHR found small statistically significant improvements in symptoms of PTSD, quality of life, stigma, and perceived social support, as well as non-significant improvements having been observed in symptoms of depression, anxiety, stress, and alcohol use. So hypotheses were confirmed, and of course, this is very promising for the BOSS program. And the direction that the research, these are the outcomes that we're certainly hoping to see. Very exciting to get those research results. And then, of course, in spring of 2020, everything changed, and we needed to modify the program to adapt to the current state of the world. And so we adapted BOSS to be for a virtual delivery. And in the modification process, we determined that we would, rather than 2 hours a week for 8 weeks, we cut it down to 1 hour per week for 8 weeks with up to 15 participants, with the idea that we would emphasize the psychoeducation piece over the group processing and the peer support that can happen in in-person delivery, largely because it's really difficult to try to recreate virtually what happens in person when you bring 10 people in the room together and get them talking in a sort of vulnerable way facilitated by a clinician. And thus far, we've had, very excitingly, 623 BOSS participants in total, 433 of which have participated in the virtual delivery. So virtual delivery seems to be where it's at. It's the direction that things are going these days, given the state of the world. And so this is very exciting adaptation that we've been able to provide for what has been a very promising program. And certainly, just like with the in-person delivery, we need to make sure that we're continuing to do research on mental health outcomes with the virtual delivery. So along those lines, some disadvantages, unfortunately, of virtual BOSS are that the evaluation by the amazing CIMVHR team has shown no statistically significant improvements in the virtual group, which we've got some theories around. That's tough. It's tough information to take in, but something that we need to consider and evaluate and just continue on from based off of what the data is showing us. So other drawbacks of virtual BOSS include less opportunity to engage with participants, both for the clinician and for the participants themselves. So they don't get to know each other. There aren't these sort of meaningful, vulnerable disclosures and conversations happening. The process-oriented sort of discussions aren't happening. And that's certainly a drawback. Zoom fatigue is very real, staring at screens, right? It's hard on all of us, as you may be experiencing in this moment while I'm talking. So certainly that's a disadvantage of the virtual delivery and virtual delivery of anything these days, to be frank. The virtual BOSS delivery is more passive learning, you could say. So the onus is really on members to take the material between sessions, apply it, process it, make personal meaning out of it, without the ability to actually do that amongst themselves with a clinician as it would be facilitated by a clinician. And so there's no opportunity to practice skills in the group either, which is something that we are able to do with the in-person delivery. So that's another drawback, of course. Lack of discussions, which would enhance the personal meaning of content. Occasional tech issues, of course, and then the potential for engagement issues, with some participants deciding to keep their video off for the entirety of the program. You've probably experienced this in meetings yourselves. It's certainly more difficult. I think it can compromise potentially the engagement of participants when everyone has their video off. And it's just a very different platform or just experience than that kind of in-person space where you've got the nonverbal cues. Everyone's there, everyone's paying attention and engaged, and that certainly has potential to be a different kind of agent of change as compared with the virtual delivery of education. Nonetheless, despite these drawbacks, the virtual adaptation of program delivery remains critical given the ongoing COVID waves. And so we've got to continue to research this and see whatever we need to do, who to apply Virtual BOSS to in terms of suitability for the program, as well as what can we do to enhance the delivery and the processing that we want to happen related to the psychoeducational content. Lots of really advantageous aspects of Virtual BOSS as well, however. So Virtual BOSS is more accessible for participants. They can participate from home. I've had one participant, they didn't want to miss it. They were on holiday and they were phoning it in from on a hike. So every once in a while, turn their camera on and show the rest of the group members the amazing sights that they would see. So you can, the mobile access is possible from anywhere. Registration for the mental health professional in the province of delivery is not necessary. So that means that I can deliver Virtual BOSS in provinces where I'm not registered. I'm registered in Alberta and Ontario. I can deliver it otherwise because I'm just teaching. I'm not necessarily facilitating a therapeutic intervention or a group process necessarily. And then in addition, participants therefore have the potential to have more access to psychologists and clinicians who've got that public safety mental health expertise, which we know is really critical for this population. And we also can bring participants in from different provinces. So again, huge advantages of virtual versus the in-person delivery. No commute to participate as well. Less time commitment. It's more economical because it's less time. More participants can enroll at a time as compared with standard BOSS. So with standard BOSS, we've got a limit of 10. We cap it at 10 participants. With virtual, we cap it at 15. And there is still potential for new social supports developing, even though they don't have as much opportunity to process. I've specifically seen this with participants who are in very remote rural areas, who don't have access to clinicians and who don't have a lot of face-to-face time or contact with their colleagues or their peers. And so Virtual BOSS allows for that kind of connection for folks who are geographically distant from one another. And then participants in need of triaging, in need of additional social support or professional support rather, a professional support can reach out to the facilitator in a more anonymous manner than face-to-face would allow. So they can sometimes it's easier to send a message and say, I need some help, as compared with approaching a clinician, which can feel daunting to somebody who's never sought out mental health support. Certainly qualitative feedback is important to take into consideration, given the fact that the quantitative outcomes are not as we'd hoped. And so these are some examples of some of the qualitative feedback that we have received from BOSS participants, one of which says, BOSS has really helped me to understand me, but also other people that are having mental health issues. Before I would just see folks as, I can't read it exactly because my screen is covering the quote completely, but before I would get angry and frustrated with people that couldn't control their emotions. And now I'm able to take a step back and understand why they've mentally blown up or broke down and work with them to get back to a place where you can safely deal with them. So this response, this feedback really highlights the benefits of Virtual BOSS, not just for the member, but also for the member supporting their other members, their fellow members. So very helpful for leadership as well as peer support members as well, for them to have that psychoeducational content and that understanding. Another piece of feedback we got was the BOSS program is integral for every new recruit prior to operational stress. The wealth of skills and knowledge are important in proactively managing trauma stress. For us old dogs in the program, it will drum up past traumatic events. In my experience, although painful, I feel blessed that there's help for me available and support too. BOSS is an extremely important program for first responders. So we can't ignore this really positive qualitative feedback. And these are just a couple of examples. As I've delivered a lot of virtual programs, I've gotten a resounding positive feedback as well, qualitatively speaking. So with that in mind, let's consider what are the clinical implications for BOSS Virtual, given the fact that we've not necessarily seen the same mental health outcomes as we have for the in-person delivery. So BOSS Virtual may be considered for non-symptomatic public safety members who are seeking the content, the education, but not in need of clinical or therapeutic support. BOSS Virtual may be appropriate for early career public safety members, which is kind of the idea of before operational stress, right? In theory. So folks who have not necessarily experienced operational stress may not be symptomatic, but can then be potentially equipped with the education and the information they need in advance of entering into the career, early on into their career. And then it may be utilized as an educational adjunct to psychological treatment for symptomatic participants who live remotely. So my thinking around that is the idea that if someone's in treatment, they could undergo, participate in virtual BOSS, and then actually take that material to their therapist and make personal meaning out of the material in that respect. Future directions, breakout rooms in the virtual delivery should be explored to potentially enhance engagement and social connectedness, just to get folks talking, get relationships building. Longer sessions and process-oriented discussions could be facilitated within groups in which members have previously established relationships or in the process of figuring this out right now, with one group who's voiced interest in the 2 hours together for them to process together because they already know each other, but they don't want to meet in person. And so we'll see how that goes. That's a potentially promising future direction of the virtual delivery. It'll be interesting to see what those outcomes look like relative to the other virtual deliveries. Self-directed presentation of pre-recorded sessions will be made available in winter of 2021. So that means Dr. McElhern, myself, as well as another highly talented clinician that we've got, Dr. Andrew Carlquist in Ontario, we are recording our delivery of BOSS Virtual so that members can walk through the material themselves on their own. And to get the information in that way would be more economical and less of a scheduling issue. And then future research should certainly continue to collect data and analyze qualitative responses. This is my information. Again, you can call me Mila. My name is hard to pronounce, Dr. Milis Passojovic. And these are the references that I've utilized for this presentation. Thank you very much for your time and attention.
Thank you so much again for your terrific presentation, and my sincere apologies for mispronouncing your name. I'll keep trying, and until then, I'll use Dr. Mila as you've suggested. Your presentation is really important for many reasons, I think, and it's helped to showcase some important opportunities for developing evidence-informed practices into evidence-based practices so we can proactively support mental health using qualitative and quantitative research methods, as well as how practice and research can really work collaboratively to maximize innovative benefits for the front line. So we do have some questions that have come in from our audience already, which is terrific. What has been the most difficult aspect of changing this program to a virtual delivery from a clinical perspective?
Oh, I appreciate that question, and thanks for the wonderful feedback. And it's totally okay on my name. I think not being able to develop a rapport with the participants is probably the most difficult aspect of the work in terms of the virtual delivery and the adaptation. When you've got people in the room, you can have some sense of how they're making meaning of the material, how they're processing it. You can read nonverbal cues. When people have their cameras off, of course, it's difficult to develop a rapport, and you just don't know how the material is landing. So I give my contact information, I invite them to ask questions, but when someone's got their video off the entire time, there's always a part of me that worries about kind of how that material is landing and if they do feel comfortable to reach out for that additional support.
That's great. Thank you very much. I can only imagine how challenging that is. And it's something that we were all sort of thrown into really rapidly because of the COVID-19 challenges. We have a second question. Which public safety personnel populations has BOSS been delivered to? And is there a plan to adapt the program to other populations?
Yeah, so we have delivered BOSS to firefighters, police officers, and emergency workers. EMS and paramedics. We've also adapted the program to Crown prosecutors. So we've done in-person deliveries for Crown prosecutors. They've indicated they do not want the virtual delivery, they just want the in-person. We've also adapted it to global security workers, and we are in the process right now of adapting it to nurses and healthcare workers as well, in order to continue adapting to the current conditions that we're all living in.
That's fantastic. Thank you very much. And thank you so much for the work that you and your team are doing, and for being so actively and proactively, if you'll forgive the pun, engaged with research as you're going through. I'm very excited about the next steps for all of us and for you. So thank you.
Thank you.
Next, we have in our presentation series, Dr. Shaylee Bolton, who's an award-winning assistant professor at the Department of Psychiatry at the University of Manitoba. She is the research coordinator for the Manitoba Population Mental Health Research Group, led by Dr. Jitendra Sareen. Dr. Bolton's research expertise lies in the area of psychiatric epidemiology, suicide and suicidal behaviors, traumatic life events, and at-risk populations. She also has extensive expertise in randomized controlled trials and program evaluations. Please join me in welcoming Dr. Plouffe.
So good morning. I'm here to talk to you a little bit about a recent evaluation that our team had done, looking at a class-based model of cognitive behavior therapy and using that program within public safety personnel. So this is a randomized controlled trial that we had recently done. First of all, I just want to acknowledge the large team that is involved with the research and development of this program, as well as, really importantly, the Participant Advisory Committee that we have involved in the project. We have representation from a number of public safety organizations, as well as Safe Work Manitoba, and without these people, we could never have done this project. I will mention the couple of grants that we have received, one from CIHR and one from the Workers' Compensation Board, which both funded the work that we've done here today. So these are the disclosures that I have. And the funders did not have any role in the conceptualization or interpretation of any of the findings that I'm talking about here today. So at the end of the study, I'm hoping to have made you a little bit more aware of what the CBTM classes are. I'll explain what we have done in terms of our randomized controlled trial in public safety personnel here in Manitoba. And hopefully you'll get a sense of the potential symptom reductions that CBTM classes can offer, particularly from our findings in this pilot study. So these CBTM classes really came from a vision. What we know is that a number of people are interested and would like to access psychotherapy, particularly CBT. The problem is that there is not rapid access to this program, particularly in the publicly funded system. And so the idea from a number of clinicians in the department where I work is that we would like to increase access to CBT in terms of providing this for people for prevention and also for treatment of their mental health problems. So this led us to really come up with the idea of what can we do differently? What can be innovative in terms of people accessing CBT? And what we came up with is the idea of a class-based model. So as I mentioned, it's not readily accessible for people to access CBT very easily and very quickly. We were noticing wait times between 12 and 18 months for an individual to be able to access CBT. What we also know from research is that some of the low-intensity CBT interventions, things like accessing resources on an online format, being able to access books about CBT, with minimal therapist assistance, has actually been shown to be quite cost-effective and a way to improve access. The other piece is that everyone in their lifetime at some point has been in a class, whether it's in school or in some sort of other program. But not everyone has been to therapy, and not everyone wants to be in therapy. So we thought this was a real good way to reduce the stigma associated with attending a therapy session. And what we found was that people that had attended the class-based kind of model for CBT, it really opened their eyes to what to expect in terms of therapy going forward. So during these classes, there's a number of things that are kind of taught or talked about it within the classes, but the main things are really the principles of CBT in terms of their use for treating depression and anxiety, the structure and kind of what happens in a CBT session, and also really providing information about where to access good quality and free self-help resources for CBT. The classes are held once a week. There are 5 sessions, and each of those sessions is 90 minutes in length. And here's a number of the topics that are covered within these sessions, things like, of course, explaining the CBT model, some relaxation strategies and mindfulness-based thoughts, behavior therapy, things about healthy living, things that include like sleep and nutrition and how to incorporate exercise into your life, problem solving and anger management skills, and then also how to respond better to stress. So after we started to implement these classes in a clinical situation, we did a chart review on a number of patients, over 500 patients. And what we found was actually that those classes, the individuals that took those classes, demonstrated that they had reductions in their depression and in their anxiety symptoms. So that was really, really strong findings, considering that this was just a very short-term 5-class session and we were already seeing some symptom change. What we also know is that public safety personnel are particularly vulnerable. They are exposed to high levels of trauma, and as a consequence, they often have high rates of mental health problems. A number of organizations have implemented the Road to Mental Readiness program, which has been really, really helpful in terms of increasing awareness of mental health problems and has really increased mental health service use in these populations. But what there haven't been findings to support is that this will actually prevent any mental health problems in the future. This led us to a major question, which is, could these CBTM classes be effective in a way of using them to prevent public safety personnel from getting mental health symptoms? And that led us to the study that we conducted. So it's called the Creating Resilient Workplaces Study, the CREW study. It's, of course, a randomized controlled prevention trial, as I mentioned. It started in August of 2019, and the main population that we used was public safety personnel. We had a target recruitment of about 120 participants. We recruited from police officers, firefighters, paramedics, emergency dispatchers, and corrections officers. And so what the goal of this project really was to get a healthy cohort. So people that did not meet criteria for mental health symptoms prior to the start of the study. So this is below symptom cutoffs on a number of really well-known measures that I'll mention in a bit. These individuals also were, we had to make sure that they had no recent history of mental health treatment, so within the last 6 months, and also that within the last 6 months they had not endorsed any suicidal thoughts. We recruited 60 participants to the study. 28 of them were randomized to receive the CBTM classes, so the 5 sessions, and then 32 of them were placed on a wait list. These individuals, both groups, completed questionnaires at baseline before each of the 5 sessions. The waitlist, of course, did it in a similar timeline of those that were in the classes, at 1 week following the classes, and at 3 months after the classes were done. The main measures that we used in the study were really changes in PTSD symptoms as measured by the PCL-5, changes in anxiety symptoms as measured by the GAD-7, changes in depressive symptoms measured by the PHQ-9, and then also this measure of resiliency. So does this build resiliency within these individuals? And that's measured by the CD-RISC-10. This is just showing you some descriptives of the sample. The mean age was about 40 years of age. The percent female was equal amongst their groups, even though there was a little bit more female representation within the waitlist. This was not a significant difference. It was the same 75% of individuals were married or common law versus single. So it really does demonstrate that the randomization worked in terms of these characteristics. When we look at the occupational representation, we see that it's about equal amongst the groups as well. Again, our randomization did block on occupational groups, so it did work, and we had equal representation across those 5 different groupings. And this demonstrates the percent of data completion that we received during the study. So you can see that those people that were in the event intervention were more engaged than those in the waitlist, which I don't think is very surprising for many people who have conducted RCTs. You can see that we had about 90% data completion. 5 or more of the 7 sessions were done, 90% of those people, and the waitlist had slightly lower at about 65%. But this is still really actually quite good data completion rates. So I'm just going to jump straight into kind of the main and key findings of the study. So this, maybe I'll just orient you a little bit to the chart. So what you can see here is there's 2 lines that demonstrate people's symptoms of post-traumatic stress disorder. So on the PCL-5, their scores. You can see that both groups started below 10. 10 is the cutoff threshold for this measure. You can see that both groups, the classes represented by the orange line and those individuals in the waitlist represented by the light blue line, you can see that they started at baseline on the far left at about the same score. So around, 8, 8.5. Then as we look across the graph, we can see that those scores change and that after class 2, those scores start to diverge. So the people in the wait list, they kind of stay about where they started, and it stays fairly flat across the 5 weeks. But amongst people who were in the CBTM classes, you can see that their PTSD symptom score goes down, and it continues to go down across those 5 classes. So you can kind of see that in here, and you can see that by class 5, there is a significant difference between the two groups. When we look from class 5 to 12 weeks, so the 3-month follow-up, we can see that the individuals who had taken the CBTM classes, their scores on the PCL had gone down and they stayed down. And that was significantly different than those in the waitlist as well. With those in the waitlist, it just stayed about the same across that follow-up period. So this really shows us that the CBTM classes were effective in changing those symptom measures and that they were effective even 3 months later. When we look at scores on depression on the PHQ-9, we see about the same trend. The waitlist and the classes group both start at about the same score at around 3. And over the 5 weeks of classes, those people that were in the classes had a reduction in scores. It was significantly different than those in the waitlist group, and it stayed down across that time period of the 3-month follow-up. And again, we see pretty much the same findings when you look at the GAD-7, the anxiety scores. When we look at resiliency, we see that the scores, again, have a similar kind of finding. In this case, we are looking for scores that are going up over time, with increases in resiliency being a good thing. And what we see is amongst individuals who were in the CBTM classes, those scores do increase across the classes and across that 3-month follow-up, and they actually continue to go up over that follow-up. This was not a significant difference, and I believe that this is probably a bit of a power issue due to the us only being able to recruit about half of what we had aimed to recruit in this study. Importantly, we just had to check about safety of the CBTM classes in these groups over time. And what you can see here is that nobody actually met criteria for PTSD during the time period of the 5 weeks of classes or the 3 months of follow-up. We had a couple of individuals that did jump above threshold for the PHQ-9 in that time, but they did quickly go back down. And then same thing with the GAD-7. We had a couple of people who within the intervention group did jump above threshold, but then again did go back down during the classes. And nobody did endorse suicidal thoughts at any point during the study. So really, the main take-home message was that we really felt that the pilot RCT that we had conducted was quite successful. We did see what we had hoped to see, what we expected to see, and we were able to recruit participants, and we got adequate follow-up from those individuals that we were able to recruit. The intervention was acceptable to participants when we asked them on another scale whether they enjoyed the classes, whether they found it useful, and these measures were quite highly endorsed by everybody that took the classes. The issue, of course, was that the study was probably somewhat underpowered to really detect the actual magnitude of the change here, and that was because we had recruited those 60 individuals, and as we were planning to recruit the other 60, COVID hit and we were unable to continue to run our in-person classes, so that really limited our ability to continue this study, and we had to end early. But the important thing is that we did find significant differences between these groups on some of the really key outcomes like PHQ-9 and PCL and GAD-7, even with our low sample size. And another thing to really consider about this study is that all of these people were actually healthy or below clinical thresholds at the start of the study, which really emphasizes the ability of this class to really change even scores amongst people that were doing quite well and maybe prevent development of future mental health problems. The other thing that we really want to aim to look at over time, which we did measure and which I've not talked about today, is the exposure to trauma that may have happened during the classes or during that follow-up period, and how whether the increase in resiliency scores may have had some impact on how that trauma impacted the individual. These are some of the references that I used in my work, and I would be happy to take any questions at this point. Thank you.
Thank you so much, Dr. Bolton, for your presentation and for your engagement in PSP research by you and your team, and for such a terrific study and despite the small sample sizes and the challenges, such terrific results to be able to see. CBT treatments and classes tailored for PSP are such important parts for managing the mental health continuum of care for all the reasons you mentioned, particularly access and overcoming stigma. So thank you. We've already got a couple of questions from our audience this morning. So starting with an attendee asking, you mentioned that COVID interrupted the study as it was designed and reduced your sample size. So are there plans now to reinitiate the work to continue the data collection, or what are your next steps going forward in that regard?
Yeah, absolutely. So it's actually quite nice that Milana was presenting right before me, because they were talking about converting their program to a virtual care program, and that's exactly what we're doing with CBTM. So we've decided that we've created Zoom-based classes, so it's very similar to what it was like in person, where we have a facilitator at just running through the information in a similar format just on Zoom. And then we've also created an online course where individuals can actually log in and just walk through the material at their own pace and on their own time. So those two different virtual kind of formats are going to be evaluated in an RCT that we've just been funded to do through CIHR. So that'll be the next steps for us.
Congratulations, that's fantastic news. We have a second question asking, this study is focused on a healthy cohort of public safety personnel with low to no mental health symptoms, yet we know that many public safety personnel are experiencing mental health symptoms right now. Can you speak more about that?
Sure. So yeah, I think that's an important point to really think about in terms of the work that we did. And the grant that we had received was really focused on kind of building that resiliency piece, or looking at whether we can prevent mental health issues. One of the things that kind of happened while we were recruiting people for this study is that, of course, a number of people came with active mental health symptoms that they were not being treated for, or high levels of PTSD. Specifically. And so what we noticed that we really didn't want to not offer this program to those individuals. At first, we had kind of contemplated removing them from the study, which we did in terms of the evaluation that I presented, but they were really quite desperate to get any kind of care or help that they could, or any kind of skill learning that they could get. So going forward, and particularly with the virtual evaluation that we're going to be doing, we are not going to be limiting it to people that are a healthy cohort. We are going to be sure to include everybody that is all comers from PSP, whether they have clinical symptoms, whether they're being treated for those symptoms or not. And we're going to see what happens in terms of the findings, and whether those particular individuals maybe even do better than what we saw in the healthy cohort, or if it's not as effective when you are above threshold symptoms. So that'll be the next steps for us.
That's fantastic, and congratulations again on the terrific successes, and I'm looking forward to seeing more as we go forward. So thank you again to you and your team. So next up for our presentations this afternoon now, we have Dr. Kelly Dean Schwartz, who is also an award-winning associate professor in the School of Applied Child Psychology. He's a registered psychologist since 1993 and began his career with a Calgary school board, and has worked extensively with children and adolescents who have severe learning and or social or emotional needs. He's also currently serving with the CIPCERT Clinical Subcommittee. Please join me in welcoming Dr. Schwartz.
All right. Hello, everybody. My name is Dr. Kelly Dean Schwartz, coming to you from Calgary, Alberta. It is great to be with you at CIMVHR Forum this year. We'll go through some presenter slides here at the beginning. Pleased this year to report that we are funded in the study that I'm going to share with you by Canadian Institutes of Health Research and CIPCERT, who have a partnership grant for the study. So I'm pleased to acknowledge them today. Also for disclosure of financial support, again, we have an operating grant from CIHR, but there are no conflicts of interest. I do not have any potential bias to declare. And here's the learning objectives that you saw. So hoping that you will come to understand both the complementary and unique needs and strengths of public safety personnel and their families who may be experiencing operational stress impacts on their mental health, their family relationships, and coping. And there is my reference list for you that you can check out afterwards. So yeah, the title of our presentation today is Constructing Interventions for Families, First Responder Families. And I'm showing you just a small piece of this much larger study where I'm sharing with you the survey results that we did with PSP members and their families. And so this is an overview of the results we had. I'm the PI on this project, but as you'll see in my last slide today, I represent a much larger team of researchers on this project, and I'm happy to and proud to introduce those folks to you. I know in talking to this audience that I don't need to go into a lot of background on what the experiences are, and I've kind of cheekily used the title of an old Army recruitment message I used to see on the TV. There's no life like it. Certainly the life of a first responder is different from mine and different from most of the public. We know from several years of research that as a function of their occupations, first responders are exposed to a wide variety of what are called potentially traumatic events, or PTEs. And as a result of experiencing these, either directly or indirectly, the impact of this on their functioning is thankfully now being studied much more prominently than it was even 10 or 12 years ago. I cite our colleague Nick Carlton and the work of CIMVHR, the results of a large survey of Canadian first responders, or PSP, where in fact they found that of the PTE types experienced, approximately 11 out of 16 of those types that were assessed, and with each type experienced 11 more times by over 7 out of 10 of those respondents. And here is directly from that study, looking at some of the PTEs that first responders experience. You can see that on the left-hand column. I just highlight on the right-hand column how, when we're looking at, compared to the general public, the odds ratio of experiencing those as part of their occupation. And you can see that as soon as we get, over anything over a 1.0 odds, that we're talking about, a heightened frequency of PSP members experiencing these PTEs. So again, this is the impetus for our study, as we acknowledge that first responders are at risk for experiencing these PTEs. And we acknowledge too that if you experience one, you likely experience several. And as a result of this, we're of course very interested in the impact on the functioning of that PSP member. Our study, though, the uniqueness of it is that in addition to, of course, being interested in and aware of the impact of PTEs on first responders, we also want to look at how PSP members might be experiencing either a PTSD or a PTSI, a post-traumatic stress injury, and then how those are experienced within the family unit. And again, comparatively speaking, the literature is growing, but still comparatively small on the impact of operational stressors and operational stress injuries on that first responder family. And again, there's been some studies over the years that you can see here, some on spouses, but even less on children and youth. And again, a recent study by Nick Carlton and the CIMVHR group that despite more and more evidence showing that family members bear the brunt of both the stigma and the lack of understanding experienced by first responders, they are also the primary resource that are identified by first responders as being the source of support. And again, I pull out one slide here from that 2020 study that shows, again, when first responders are asked who they access as a resource, you can see that overwhelmingly spouses, whether that PSP member has received training or not, overwhelmingly almost 3 out of 4 PSP members say that the spouse is the first resource they go to. So this was the real impetus for our study in that, and you can see the title of our study here, where we are evaluating and developing a novel psychosocial intervention for PSP and their families. And so we were pleased to receive this grant in early 2020. We're into the second year of our study on this. And here's the purpose. What we intend to do is to design and examine the effect of a psychoeducation and support program for PSP family members. We're only focusing on 3 of those PSP groups: police, fire, and paramedic. And it's really a twofold purpose. We want to address the specific and shared needs and strengths of PSP families, and you're going to hear part of that today. And then by extension, we hope to develop this intervention program that will strengthen the mental and social health of the PSP member as we strengthen those areas in the PSP family. So we are informing our design by going and collecting data directly from the lives and lived experience of PSP families. So first thing was to hear from PSP and family members about their needs and strengths. That's what you're going to hear today. Then we are in the busy work of building and piloting a PSP family program. And then in the next year and a half, we will evaluate the efficacy for change as a result of that PSP family program. So kind of a 3-step process, and you're hearing about the earliest of that in step 1 today. So what we did was we constructed 2 data collection sources. One was a set of focus groups, and unfortunately we don't have time to share that with you today, but we do have an upcoming article on the results of our focus group with families. But that then informed the online survey that we did with a sample of PSP members and their families. I'm just showing you kind of the general demographics that we measured, so you can see how we kind of contextualized, and that's going to be really important later on, contextualize the results. And here's some sample questions that we asked within our online survey. So we asked them questions like, how helpful are each of these below programs for PSP families? So, well, you know, if we had a program that talked about understanding operational stress and what OSIs are all about, understanding how operational stress can affect families, get support by meeting with other PSP families who are dealing with current stressors. So we wanted to know how important each one of those components were in a program. Then we asked them to choose their top 5, and again, I'll share those results with you. And then we wanted to know too, of course, COVID really changed this for all of us, was to rate the delivery options that would be most helpful and would work with PSP family schedules, because as we know, that's such an important area of understanding as well within this group. So we were privileged to do this in early 2021. We collected results from, as you can see, PSP members, spouses, and partners. And then we had a very small group who were both a PSP and a spouse partner. So you can see there we had approximately 152 individuals complete our online survey. You can see that we were overrepresented in Alberta in terms of the respondents. Pretty nice balance between male and female. And then, of course, very interesting to us as we talk about a family intervention program was what kind of families, you know, in terms of the structure that they came from. And so you can see almost 7 out of 10 were 2-parent biological families, just over 10% 2-parent step families, and then some others who were 2-parent blended or 2-parent adopted families. So keep that in mind. In fact, I'll revisit that when we get to our results section. So what did we find? Well, again, as you saw, we asked them questions about thinking about first responder families in general. Tell us how important you think each one of these topics listed below would be to a program if it was offered to first responder families. And you can see that, generally speaking, there was a little bit of difference between what first responders, that are the red bars, spouses or partners, which are the yellow bars, and then the small group of respondents we had who were both PSP members and families. PSP members and spouses. And you can see that in all cases, understanding kind of the general area of operational stressors, how it affects physical health and behavior, how it affects thinking. In all cases, the spouses or partner rated those higher. But when we did our analysis of these for statistical significance, none of these were significant. That changed when we asked them questions that had to do with general areas of families and parenting. Now we did see some statistical differences, significant differences, and you can see in two areas, one about family communication, another one about helping parents and children understand operational stress and how to cope with it. Now we saw those differences between what the PSP or first responder was how they ranked or rated these items versus how the spouse rated these. And so again, you can start to see some separation in thinking about and learning about how operational stress impacts the families. We then had them choose or rate the top 5, and I'm pulling out where we saw good consistency across all 3 of our kind of respondent groups. And you can see there's 3 that really stood out. One was how to understand operational stress and its effect on families. Another one on understanding how operational stress can affect behaviors. And then understanding how to cope with operational stress. So those were the 3 that found the most consistency in high rankings in the top 5 amongst the first responder, the spouse partner, and then those who were both a PSP member and a spouse. So again, you can see that even though all these areas are important, all these areas deserve some attention within a psychoeducation and support program, there are some that kind of filter to the top as being ranked more highly than others. The last slide I'll show you is we did an exploratory factor analysis to see if we could actually get all of our items to hang together in certain topic areas or variables. And we found that, yeah, there was 3: operational stress, injury understanding, parenting and communication, and then a parenting and family support variable. So much more of a peer support or a relational support variable. Here we found differences, as you can see, between males and females. So females rating the OSI understanding and family peer support higher than males. Go down to the middle group there. We also found that in all cases, spouses or partners rated these 3 areas in the mean scores higher than did the first responders. But then we had that small group, and remember, this is only 10 participants in our study, but who were both a first responder and a spouse. And there we found that they were statistically significant in their rating differences of these compared to both the spouse partner and the first responder. Then finally, we also found differences between families that had children versus families with no children. Not surprisingly, parenting and communication and family peer support were rated more highly for those who were representing families who had children compared to those who did not. So what does this all mean? Well, it means that overall the findings suggest that certainly operational stress is actively impacting the functioning of our PSP families. We identified areas of support in addressing impacts of operational stress and that they differ between PSP members and spouses, in some cases between males and females, and in some cases between those who were from families with children compared to those families without children. In almost all cases, spouses identified needs related to parenting and family higher than the first responders themselves. And what this means is that it says to us that as we're constructing the psychoeducation and support program for first responder families, that we need to consider intra-family needs, so what's going on within the family, and then also match that with, again, some trauma-informed support. And you can see on the bottom, we're working, again, according to a trauma-informed model that runs all the way from prevention, little support needed, more psychoeducation, all the way to, much more individualized therapeutic and maybe more intensive supports. And we're trying to figure out where our psychoeducation and support program fits within that. And as we design the program, that's very important for us. So moving forward, as I said, we're pleased to have this CIHR grant that is going to allow us to explore the efficacy of this psychoeducation and support program that we're calling PSP Family. We're going to do this with police and fire and paramedic families in 3 provinces, Alberta, Saskatchewan, and Ontario. So our next steps are to use our focus group and online survey results and the existing literature to design, pilot, and evaluate our PSP family program for spouses and partners. And then, of course, with COVID, it really forced us to think about our delivery options. And we've come to conclude that it's going to include both an asynchronous, so a kind of a psychoeducation learning component, and a synchronous peer delivery component. And then what we're going to do is pre and post test using self-report and using biometric wearables to see if this actually impacts on any of the physiological functioning. So again, we're hoping to pilot these PSP groups starting early in 2022. And as a final word, again, we're so pleased that we're going to contribute to a literature that really stresses the importance of building evidence-based supports and interventions for our first responder families. Lastly, I just want to, as I said to you, I'm the PI on this project, but I represent a wonderful team of fellow researchers, postdoctoral scholars, graduate students, and project coordinators. So just very pleased to present this to you, and hopefully next year we'll come back with some preliminary results on the piloting of our psychoeducation and support program. So thanks for attending, and look forward to our discussion together.
Thank you so much for your presentation and for how engaged you and your team are with PSP research, particularly focused on families, where I don't think I've made any secret about the fact that I think we have huge opportunities there to make real and impactful gains for PSP, but also for their families who are experiencing their own challenges and as a result of the PSP service. So I'm super excited about these next steps. We've got some questions from our audience already though this morning, so maybe we'll jump into those. Your survey results indicate that there were 3 main areas: understanding how operational stress can affect families, how it impacts behaviors, and how to cope with operational stress. Those were areas that PSP and spouses identified as important for this program. Has your study also been able to uncover any more specific areas of strength and or need for our PSP families?
Yeah, thanks, Nick. One part that we wish we could have presented was the results of our focus groups, which was so informative to us. And yeah, in addition to kind of what we expected in terms of understanding the effects of operational stress, both on the PSP member and how that filters down to the family. We also learned from our PSP families that they had some other unique areas of functioning that we might be able to address in our program. One being things like connection and disconnection. Like how does the family connect with a PSP member when he or she comes off shift, goes back onto shift, and we know about that, the timeline of the ebb and flow of how a work week goes for a PSP family. And so that notion of how does the family connect with their spouse or with their dad or mom when they come back off shift. So that was one of the areas. Of course, balancing work and family values, the importance of the important work that PSP members do for the community. How does the family balance that with what their needs are as well, what they need for that PSP member when he or she is home? And then lastly, one of the areas we found out about that was really important was the notion of, or the factor of identity, like how PSP families are defining themselves both within their family unit, but then how that also interacts with the community. And of course, this is really important as families come to terms with how they represent themselves, how they are represented in the community in sometimes mostly positive ways, but also sometimes in negative ways, especially during COVID when we've all heard about the stresses and strains on PSP families. So that really came out in spades too, and we hope to address some of that within our psychoeducation and support program moving forward as well.
Fantastic. I'm very excited to see the results that are up and coming, and I'm glad you're able to share some of those additional qualitative results. We've also got a second question asking, can you describe in more detail how the biometric wearables will be used in your study?
Yeah, that's pretty exciting for us. We're working with a couple of my colleagues at the University of Calgary here who are doing this work with one of my colleagues, Linda Duffet-Leger, is doing this with nursing colleagues and looking at using biometric wearables such as a Garmin, watch, and they're running kind of live stream data on how, in their case, nursing professionals go through their workday, the ebb and flow of the stress levels that they experience, their activity levels. Do they have down times physiologically that are important to recovery and recuperation? Well, we want to see that too with our PSP and PSP family members in terms of tracking them during the time that we're offering the family program, just to see what changes over the course of a 4 to 6 week period of time for them in terms of their biometric variables. So we're pretty excited about this. This is brand new for me. Don't ask me any technical questions because I leave that to my other experts on my team, but we're pretty excited about it.
That's terrific. Thank you so much, Kelly, for all of the work that you're doing, and we're certainly excited as well. Good afternoon, all, and welcome back. I'm very pleased to introduce our next speaker today, Milis Voth. She's currently a third-year student completing her master's in occupational therapy at the University of Alberta. She also works as a research assistant with the Highmark Lab at the University of Alberta, with a primary focus on increasing readiness, resilience, and growth of our military members, veterans, and our PSP. Please join me in welcoming Milis Voth.
Great. Hello, everyone, and welcome to our presentation on the efficacy, effectiveness, and quality of resilience-building mobile applications for military, veteran, and public safety personnel, or PSP. My name is Milis Voth, and I'll be presenting today on behalf of our research team. My co-authors and I have no known conflicts of interest to disclose for this study. Right, so our learning objectives for this presentation include a reflection on the potential benefits of using mHealth apps for the listed populations in order to promote resilience and engagement in mental health care, to recognize the qualities mHealth apps for resilience and mental health should encompass in order to be safe, effective, usable, and confidential for use in a healthcare context, as well as to identify the need for further research and an increased partnership in the development of use of mHealth apps. So globally, military members and public safety personnel, or PSP, are vulnerable to occupational stress injuries due to their job demands. Consequently, when military members and PSP transition out of these professions, they may continue to experience mental health challenges. In response to this, resilience-building programs are being developed and implemented with the goal of promoting empowerment and primary stress regulation. The development of mobile health or mHealth apps as an emergent mental health intervention platform has allowed for targeted, cost-effective, and easily accessible treatment when in-person therapy may be limited or unavailable. However, current mHealth app development is not regulated and often lacks both clear evidence-based research and the input of healthcare professionals. The purpose of our study was to evaluate the evidence-based quality, efficacy, and effectiveness of research-building mobile apps targeted towards military members, PSP, and veteran populations through two methods. So our first was to conduct a scoping literature review of the current evidence base regarding resilience apps for these populations. And our second task was to complete an evaluation of free resilience apps designed for use amongst these populations. Studies were selected through a search of 7 databases that was guided by Prisma for scoping reviews. And the Alberta Rating Index for Apps, or the RAF, was used to conduct a review of each of the identified studies. In total, we had 32 articles that met the criteria and were included within the study. And from those articles, 22 apps were identified and reviewed by researchers. For the literature review, we focused on studies published from 2000 onward to account for more current technology, as well as studies focusing on military or PSP populations, and articles chosen also address resiliency, hardiness, or coping. And then for the resilience-based application review, we focused on apps available on the Apple App Store and Google Play Store, and apps that were free to download, as research has shown that individuals are more likely to download apps free of charge. Additionally, we only included apps available in English, with the intended population being military members or PSP populations. The ARIA was used as a measuring tool to rate each app included in the study. So there are two versions of the ARIA, one for care providers and one for users. And it's available in both English and French, allowing it to be used across Canada, and particularly with all PSP and members of CAF and Veteran Affairs Canada. Sections A and B are added together to determine an overall score of 72, with higher scores indicating better performance and user experience. The care provider version of the ARIA was chosen to review the selected apps due to its ability to be implemented by users, caregivers, and healthcare providers. And each identified app that met the eligibility criteria was evaluated by 2 reviewers using the ARIA. Conflicts were resolved through discussion with all researchers to determine the final ARIA score. So here's the care provider version of the ARIA, and this was what was used by the authors to review the apps. So when all 22 apps met the inclusion criteria for evaluation, resilience strategies offered by the majority of these apps included psychoeducation, mindfulness, cognitive behavioral therapy, and acceptance and commitment therapy. 11 of the apps, so 50%, had been tested randomized control trials. 7 were evaluated using other research methods, and 5 had not been researched. The literature indicates that 15 of the 22 apps utilize evidence-based strategies or incorporate evidence-based components within them, and 11 of the 15 apps were developed using evidence-based practices as their foundation. Using the ARIA, app scores ranged from 37 to 56 out of 72, and higher-rated apps demonstrated increased usability and security features. And the highest overall scoring apps in the study were R2MR, PTSD Coach, and AIMS for Anger Management, which all had a total score of 56 out of 72. The majority of the health apps reviewed in this study are well suited to provide resilience strategies for military members, PSP, and veterans. Of the apps assessed, 15 were developed by credible military-focused government agencies, such as VAC and the U.S. Department of Veterans Affairs, which ensures the content delivered is well adapted for these populations. When considering recommendations for clients, healthcare professionals can apply tools such as the ARIA to consider multiple aspects of the app and how it might best support treatment. It is important to note that many of these apps perform best when combined with the services of healthcare professionals. This could include providing learning sessions prior to use to increase efficacy and optimal use patterns, providing weekly phone check-ins, or even using the apps to enhance existing therapeutic interactions between clinicians and users. In much of the literature, gamification and the integration of social components strengthened mHealth app use and engagement, which resulted in greater positive outcomes and an increased sense of peer support for both military members and PSP populations. However, this tends to be lacking in practice. Future comparisons of the ARIA with other app evaluation tools may allow for more in-depth understanding of mHealth apps. However, we chose the ARIA because for military members and PSP populations, its additional security and privacy questions provided a clear understanding of population-specific concerns. Healthcare professionals have a responsibility to advocate for best practices, and this can be challenging with mHealth due to the high rate of app development and an inability for evidence-based practice to keep up. Using tools like the ARIA can help clinicians determine an app's usability and evidence base. However, healthcare professionals must also ensure the app is a good fit for their clients in terms of their interests, values, abilities, and routines. Healthcare professionals can then use this information to collaborate with the client and customize apps that meet the client's needs and interests, as well as promote engagement with the apps. Creating client autonomy through app literacy will also allow users to take more control in choosing treatment methods and encourage greater client-centered practice. So resilience is often targeted by healthcare professionals through interventions that strengthen social support systems, foster greater self-concept, encourage optimism, promote the ability to reflect, and build emotional strength. While not intended to function as a substitute for professional services and interventions, mHealth apps have the potential to foster resilience and support a significant reduction in symptom severity for different OSIs, including PTSD, depression, and anxiety, within populations affected by OSIs, such as military members, veterans, and PSP. Apps provide easy accessibility to evidence-based tools and encourage users to initiate help-seeking behaviors when stigma or uncertainty may impede the use of direct care. Within clinical practice, healthcare professionals can assist clients in identifying apps that support their habits and values, bolster participation and engagement in activities of daily living. As accessible, novel, and evidence-based interventions and resources for fostering resilience and addressing mental health become available, military members, veterans, and PSP populations may be able to facilitate healing, recovery, and growth that has a positive effect on their families, community, organizations, as well as the public that they serve. So we'd just like to give a quick acknowledgement to the support of Dr. Payman and his team in guiding us through the use of the ARIA, as well as the support to the Highmark Research Lab team members. Thank you so much for attending our presentation, and we're happy to answer any questions that you may have. And just a few slides of our references, which I'll put up for anyone that's interested.
Fantastic job, Melissa. Thank you so much for your presentation today and for choosing to engage in this really important area of research where we certainly need more and more people to become engaged with the supports that are necessary. I think the work you're doing is really interesting and exciting and important for a lot of different reasons. And your team has done a great job of not only providing results that I think are so important, but showcasing a process to try and help everybody navigate just the tremendous explosion of apps and services that are happening right now across the country to try and work with PSP, military, and veterans. So great job on that. We do have some questions from our audience that we'll get started with. So when comparing information gained from the literature around building resiliency to what the apps evaluated offered, was there anything that was sort of consistently missing and or consistently present within the apps?
Yeah, so when looking at the research, many of the theoretical models of resilience often tend to look at both intrinsic systems, so things like coping skills, and extrinsic systems, so social supports. Both is quite important in developing and maintaining emotional resilience. Many of the apps were great at promoting those intrinsic systems, but the intrinsic components tend to be missing more often. So ones that we came across the most were social components are quite difficult to put into apps, especially when considering the privacy features. So those would be important to look at in the future because they could potentially help strengthen adherence and positive outcomes as well as user engagement. Often one of the other things that tended to be missing was just a description for people who might be using the apps about the risks associated with their use, as well as some of the security components, which of course are quite important when you're inputting very personal information. Saying that the apps were all very good at targeting the appropriate populations. As was mentioned in the presentation, many of them were created by military or known developers. So you have that directed care. And as all of the apps that we went over were also free of cost. There were some that did have a small cost, but they were all very good at making it affordable and accessible for the populations.
That's really great. And what a nice nuanced job you and your team did there. You should be really proud of that work. It's really terrific. So we have a second question. What are some of the steps that might be taken in the development of future apps in order to increase use, or the revision of current apps to increase usability and effectiveness for the population?
Yeah, so of course, with apps coming out, they're coming out fast and furious. So one of the biggest things would be increased research and regulations around the apps and the programs, just to make sure they're following some sort of standard to ensure we're giving the best care. One of the other things that tend to come out of our research as well was making sure we're equipping users with an appropriate level of digital literacy so they can successfully and effectively use the apps. And that could be working with clinicians to find out how it might tie in with their current care, or it could be providing orientation sessions, which some of the app developers did do and found increases in how the apps were effective for their participants. Another thing that came up was maintaining a sense of separation of the app from employers, is sometimes that can increase the desire to use it if individuals know it's not going to get back to employers or affect their careers at all. And then, of course, including experts in the development of apps is always important, but it's also important to include the users themselves in determining what features should be considered. So using that collaborative approach to development. And finally, usability. One of the biggest things that participants in the research studies noted was having a sense of progression within the app. So something that had a rhythm or set goals or targets that they were working towards. So they kind of knew they were going forward, as well as having those practical applications within the app. So it's not just on your phone, you're doing these exercises, but it's being translated to real life application.
That's terrific. Thank you. Thank you so much. And I sincerely hope you continue to stay engaged with the PSP research as you go forward in your career. So thank you very much again.
Thank you.
So next we have Dr. Megan Idgelow, who is an assistant professor in the School of Rehabilitation Therapy with teaching and research and supervision responsibilities in the occupational therapy and rehabilitation and health leadership programs. She has clinical, teaching, and research experience in the areas of mental health, work, and activity participation. She also has a clinical occupational therapy practice serving workers with mental health conditions, including operational stress injuries, and she is actively participating in a variety of different capacities as we try and build better supports for PSP all across the country. So please join me in welcoming Dr. Idgelow.
I'm Megan Idgelow, and I am happy to be joining you to present today a review of workplace mental health interventions and their implementation in public safety organizations. I am presenting on behalf of my research team for this project, which included Emma Schofield, Matthew McPherson, Sonam Mehta, and Aquila Ortlieb. I am a faculty member at Queen's University, and this project did include support from the Queen's University Fund for Scholarly Research and Creative Work to support the time needed for this review. We had no commercial sources of support and conflicts of interest related to those, and no commercial interests in the research. So for this afternoon's session, the learning objectives will be that attendees will understand the current focus of workplace mental health interventions in public safety settings and the implementation of these strategies, and also that this knowledge could inform the work of employers, unions, public safety personnel themselves in designing and implementing workplace mental health interventions. So when we think about why is this topic important, it's well known that operational stress injuries, including post-traumatic stress disorder, are something that is an ongoing challenge for public safety organizations and the people who work there. And over time, we've been seeing an upward trend in operational stress injury diagnoses, people needing time off work, and the staffing costs associated with that. And all of these things relate to challenges for public safety personnel, the families, and the communities that they live in. So when we think about implementation of mental health best practices, often these are currently fragmented across organizations and may not always meet employee needs. There are existing reviews out there of workplace mental health best practices generally, as well as reviews of how mental health best practices have been implemented in systems. However, to date, no review put those concepts into practice in a public safety setting. And so that was what our team worked on doing. So when we think about, creating any kind of review question, you have to think about the different concepts and populations and all of those different things. And so the question that we were asking for the scoping review that we completed was, what workplace mental health interventions exist in public safety organizations? And what are the intervention characteristics? So what are people doing? And what are the strategies being used to actually implement these interventions? And so we used Joanna Briggs' methodology for completing a scoping review. And so our population was related to public safety. The concept was about implementation strategies, as well as workplace mental health. So our review had two concepts. And then the context was employers or organizations in the realm of public safety. With the methodology, we used, as I said, the Joanna Briggs Institute, their scoping methodology. We also registered our protocol with Open Science Framework so that others could be aware that the scoping review was in progress. We searched 5 databases, which were Medline, Embase, PsycInfo, CINAHL, and Web of Science. And we also mined any relevant articles found for references in their own reference list. So after doing this searching, we ended up with an almost unmanageable number of citations, but with a strong team and removing some duplicates, we were able to get the relevant articles to a manageable number. And you'll see that at the end of the review process of the abstracts, we came out with 89 articles that were deemed to be included in the scoping review itself. So what did we find in those 89 articles? So the articles were published between 1979. So we kept the inclusion criteria quite broad because a scoping review often wants to look at the full environment. And so we found articles back as far as 1979 and all the way up to 2020 because we did the review, we did the searches last July. But about 2/3 of what we found had been published in the last decade. So we're really seeing this type of research pick up speed in the last decade, which is probably not surprising to people doing research in this realm. We had a lot coming from sort of North American and Commonwealth contexts as well as European, and much fewer papers that came from Asia or Africa. We saw a lot of quasi-experimental designs that were using control and treatment groups. So almost half of the articles found were using some sort of control and treatment group approach. And then as well, another 29 were using randomized controlled trial design. So a lot of control groups used, a lot of comparisons between groups who took an intervention and groups who didn't. And then less mixed methods, very few qualitative or cohort or cross-sectional, and just one action research design. So a real focus on quantitative methods in the studies that were included in the review. And we saw a lot of papers that were relevant to police contexts and also fire contexts. So almost 2/3 of papers found were related to police officers, and then about a quarter were related to firefighters. And then less emphasis was found on other professions, including paramedics, correctional officers, generally referred to first responders or disaster workers. And then we had a few dispatcher and probation officers included. So heavy focus on fire and police. And the majority of the studies were also focused on frontline workers and the mental health of frontline workers, so 79 of 89. What were people doing? So the interventions we found were overwhelmingly focused on stress and resilience. And so half of the studies would have fallen into a category that we might think about as being about stress management. And then another quarter of the studies looked at resilience. And we did see a trend of stress management tended to be more popular previously, whereas in the last decade, we're seeing more studies on resilience come forward, or more use of the concept of resilience. A fifth of the studies looked more generically at mental health symptoms. 14 looked more broadly at wellness, and 5 focused specifically on suicide risk and prevention. But overall, a very strong focus in the literature on stress and resilience as far as interventions. How were they going about implementing these interventions? That was one of our biggest questions. And what we really found was that a lot of group training is happening. So about 2/3 of the studies that we found focused on group training methodology. And there were a few that were individual training and online training, but really a majority were focused on group training. And some were still implementing debriefing programs, and fewer programs overall were sort of individualized to people's needs, or looking at quality improvement in a more holistic fashion at the organizational level. So only 2 of 89 were looking more broadly at quality improvement. And what we found is that with the training, most were multiple sessions, so 73% of programs that focused on training were multiple session. And the majority of programs were focused at the employee level, which makes sense because 79 of 89 of the papers were focusing on frontline workers. Very few, only 5 of the sample, were directed at leadership positions, supervisors, or managers. And those that did were focused on police and fire departments. So what we found overall is that, there was a really a strong Western focus to the research. So we probably could limit our generalizability to Western nations. And as I've already said, a really strong focus on police with a lesser focus on firefighters. And then really not much focus at all in the literature on paramedics, correctional officers, communications officers, and others. And again, that's probably not surprising to people who do research in this space. And what we know is that, there are multiple ways to implement things within organizations, which might include educational workshops, could include training and then personalized feedback for people, could also be instructional manuals, supervision and monitoring of workers or of leaders, and also could include case or video training. We really didn't see a diversity of implementation strategies. We really saw a reliance on group training, although multi-session, which we might think of as a positive movement, sometimes moving away from single session implementations that have not shown as much evidence of impact over time. But one of the things that we need to be cautious about is this focus on group training really situates the problem with the employee and often is not focusing on the external contributions of workplace culture or the work environment or the work itself and the way that it is done. And so these group trainings really put the onus on the employee to be more resilient or to manage their stress, and often don't put the focus at the organizational level. Other things that we saw that are notable was really this minimal comprehensive quality improvement approaches. So only 2 of 89 papers looking more globally at what could be improved within the organization and also following that improvement initiatives for several years. Other things we know when we look to recent systematic reviews around best practices. A recent review in 2020 looked at, what is the best evidence at the moment for the mental health programming itself. And a lot of evidence is still pointing to things like exercise and also potentially programs that involve imagery. But we really didn't see a lot of this happening in the sample. And again, there have been several reviews at this point that have recommended against debriefing programs. But despite this, our sample included 10 debriefing programs, which could make sense as well because we did not have a date limit on the reviews. And so we might be capturing older evidence as well. So things to think about with any scoping review, we were limited by the methodology in that scoping reviews map the breadth of the research and look for trends in the research, but it is not about evaluating the rigor of sources. And with any review, it's possible that using a different set of databases, different search terms at a different point in time might have yielded different results. So when we think about, how do we take this information forward? We might think about this really strong focus currently on stress management and resilience, and that we might need to think sometimes bigger about the environments and the organizations and the culture within those organizations as well, and to be cautious about loading all of the responsibility for mental wellness on the employees themselves. And also that while multi-group training could be an efficient method that is effective for some trainees, not every person might find that approach to be a fit for them personally. We're also seeing, really a strong emphasis on police in the approaches, with a sort of following focus on firefighters and really not much focus to date on paramedics, corrections officers, emergency dispatchers, and other public safety personnel categories. And so when we think about, this research space really is expanding, and I think it's incumbent upon organizations when they do roll out workplace mental health strategies to think about how to study that and how to evaluate that, so that we can continue to grow the evidence base for what kind of strategies work. So if you want to know more about the review in depth, we've got 2 different publications. So earlier in the year, our scoping review protocol was published in JBI Evidence Synthesis. And then the full review article was recently published in the International Archives of Occupational and Environmental Health. And though that publication includes a lot of detailed information about the studies themselves. I would also like to acknowledge several different levels of support that we had at the university and beyond as we completed the review, and also share with you the references related to this topic. And finally, to invite you to connect if you would like to talk more about the review or get more information about where you can find the publication. Thank you very much for your attention.
Thank you so much, Dr. Edgelow, for your presentation and your engagement, and congratulations on this research success and the publications. I'm also really grateful for your advocacy and your supports in propagating evidence-based practices or trying to shift us towards those for PSP needs. As I'm sure you know, I think the work you're doing to focus on workplace practices in particular is extremely timely and helps to fill some really important gaps that I think are fantastic opportunities to help support PSP mental health by focusing on building organizational supports to supplement and augment individual supports and resiliency. So I'm super excited to see more organizational level interventions, I hope, that are evidence-based, hopefully soon. I have many questions for you, but I thought we'd start with some of the questions from the audience, if that works for you.
Sure.
So the first question that we have is, how can public safety personnel organizations use this information right now? So how can a frontline chief or leader help their team by engaging with the information you've provided?
Right. So I think the review itself in the international archives would be useful for people to find and look at some of the particular information. There's a lot of detail on the different interventions and the ways that they were studied. I think also from a philosophical perspective, public safety leaders could be thinking more about how do we work at the organizational level. And while group training is useful and often necessary, it can't be the only strategy used when we think about overall workplace mental health. And also something that we're not seeing a lot of, even though we know it's sort of a low-hanging fruit intervention, is exercise-related interventions. These are things that any organization could be implementing, looking more at sort of the primary prevention level of health and many different chronic illnesses. I think often physical health and wellness gets kind of forgotten, and that is an intervention we have plenty of evidence to tell us is worth doing.
I'm so glad to hear that, because as we all know, as the research teams across the country know for sure, physical and mental health work together. So you're right, that's a tremendous opportunity that, I think it's certainly low-hanging fruit. So we have a second question here. What should public safety personnel employers focus on when implementing workplace mental health interventions based on your research so far?
I think, again, that focus across the continuum, that maybe you start more at the general wellness level with things that encourage work-life balance or general overall well-being, and then think about more tailored trainings and interventions that might help once people have exposures to trauma or are beginning to struggle with their mental health. So thinking about that sort of continuum. And also maybe thinking a little bit outside of the box. We seem to now actually have a plethora of resilience and stress management interventions out there that are being studied. I think there are probably some categories that we are missing out on. I don't know that anyone needs to go and now develop a new stress management or resilience-based program. I think we need to focus on maybe the ones that are out there and seeing what results we're getting out of them. And then also thinking across the organizations, what could be done sort of at the higher level about culture. Because I know, Dr. Carlton, I've heard you say it yourself, you know, we can work as hard as we can to make somebody resilient, but if they're going to be part of a really toxic workplace culture where they don't feel supported, that resilience will be worn down. So there's definitely larger responsibility at the employer level. And also one thing that we really saw in this evidence is that, you know, 9 in 10 papers essentially were focused on the front line. And we're really missing a focus on leaders and the mental health of public safety leaders as well. So I think that's maybe one of the next frontiers in this research space as well.
I agree with you on all counts, and I think that's fantastic. We did have one more question from our audience today. There seems to be a shift or a focus on some public safety personnel sectors and not others. Do you know why that is, and how we might engage other sectors in research going forward?
Yes, absolutely. So we see that overwhelming focus on police with a kind of a secondary focus on fire, and very little focus on some of our other categories. I think this is a trend across public safety research. I think these numbers probably don't come as a surprise to anyone in the space. I think sometimes it comes down to funding. It comes down to what groups are the loudest, what groups do the public see or value, who has the largest organization. So I think some of it is funding within the system. I think it's something that the Canadian government needs to be thinking more about when they are funding research proposals, that some of these lesser acknowledged groups like paramedics, dispatchers, correctional officers, border services agents, we've definitely got some neglected groups there.
Well, thank you so very much. I'm just delighted to have you as part of the large PSP research team, and I'm very excited to see some of your next steps. So thank you so much for your presentation today, and I look forward to working with you in the future.
Thanks, Dr. Carlton.
So I'm now very pleased to introduce our last speaker for the day, soon to be Dr. Justin Maas, who is currently a practicing advanced care paramedic with Peel Regional Paramedic Services, a PhD candidate at McMaster University in the Department of Health Research Methods, Evidence and Impact, and a senior fellow with the McNally Project for Paramedicine Research. Please join me now in welcoming Justin for our final presentation of the morning.
Hello, bonjour, je m'appelle Justin. I use he, him pronouns. I'm a paramedic with Peel Regional Paramedic Services, a PhD candidate in the Department of Health Research Methods, Evidence and Impact at McMaster University, and a senior fellow with the McNally Project for Paramedicine Research. And I am super excited to be talking about our work and exploring the role of organizational culture in normalizing paramedic exposure to workplace violence. Just to go through the disclosure slides really quickly on behalf of myself and my co-presenters, we broadly have no relationships with commercial interests. This research was not supported by any specific grants or research support from commercial interests. We get no speakers on our area, no consulting fees, and no other commercial interests. That said, the External Violence Against Paramedics program is an organizational mandate that is supported by Peel Regional Paramedic Services. And we have received in-kind support from the University of Windsor, who have very graciously lended us Dr. Elizabeth Donnelly. And as a paramedic with Peel Regional Paramedic Services, myself and Mandy Johnston receive employment income from the service. And we are not selling anything. So in terms of mitigating potential bias, because this work is supported by the service specifically, we do try and engage in a number of strategies to promote academic and research integrity through independence and autonomy of the research team. So in practical terms, this means that research initiatives within the service are supported and promoted by the service, provided that the research procedures are reviewed by an independent REB, in this case, the University of Windsor, and the procedures of any research themselves are approved by the paramedic leadership team, as well as the elected local executive committee of the union that represents the paramedics. But that said, the service does not make or restrict decisions on the gathering, interpreting, or disseminating findings from any research data. And the research team, ourselves, we are free to undertake, report on, and publish matters that might, for example, be critical of the service. Today, we will be talking about the epidemiology of exposure to workplace violence and paramedic work, and looking specifically at barriers to reporting violent incidents, including the role of organizational culture within the profession. Just a moment to acknowledge our team, which includes myself and my coworker, Mandy Johnston, who's a superintendent with the service and the project lead of the External Violence Against Paramedics portfolio of work, and Dr. Elizabeth Donnelly, who's an associate professor at the School of Social Work at the University of Windsor, who studies paramedic mental health. Today, what I will be talking about is a bit of background information in terms of the problem of violence against paramedics, and then getting specifically into the methods that we used in our study and how we analyzed data to develop a framework that looks at understanding organizational cultural barriers to reporting incidents of violence against paramedics, and then where we're going next in terms of next steps. So by way of background, this is a quote from a study by Brian McGuire, who's done quite a bit of work on this particular topic. And in this one, he was looking at occupational injury statistics for paramedics that had been assaulted in the course of their duty. And he was saying that these data add to the growing body of evidence that violence against paramedics is a serious public health problem. But complicating this problem is that individual incidents of violence against EMS personnel often go unreported. So in one of the very few studies that's been done on this topic in Canada, Blair Bigham, in a 2014 cross-sectional survey of paramedics in 2 provinces in Canada, found that despite the majority of participating paramedics indicating that they had been subjected to different forms of violence, most of the individual incidents were not reported to a supervisor or the police or other authority, and the vast majority were not even documented on an incident report. And so that means that from a risk mitigation perspective, it's very challenging to try and address this problem because we don't fully understand the scope of it. And when asked about why incidents of violence weren't reported, most of the people in Blair Bigham's study echo a lot of sentiments that have been described in paramedicine and in other healthcare fields as describing violence as, quote, just part of the job. But what's missing from this picture is really a more nuanced understanding of how these particular sentiments come to exist and what the implications are for mitigating this risk and enhancing provider safety. And so that was the impetus to start looking at this particular topic in our service specifically. So again, by way of background, PO Regional Paramedic Services provides land ambulance and paramedic services to about 1.5 million residents in the municipalities of Brampton, Mississauga, and Caledon. They employ 700-ish paramedics who man 65 ambulances and 8 rapid response units and work out of a centralized headquarters facility, 4 centralized headquarters facilities. And we started developing this work in 2019. And our first step there was to distribute a survey. So we wanted to get a bit of a handle on how commonly paramedics in the service experienced different forms of violence and drill down specifically on this question of whether or not these incidents are reported. And so this started with distributing a survey in the spring of 2019 that included a demographic questionnaire and asked paramedics whether or not they had experienced verbal abuse, threats and intimidation, physical assault, sexual harassment, or sexual assault over the course of their careers. Those were Likert scale or forced yes/no answers. There were a number of free text questions, though, that asked the participants to talk about these experiences in terms of the effects on their job satisfaction and their health. And in particular, the focus for this study, questions about reporting. So whether or not the incidents that they described were reported, why or why not, and what happened after the incidents were reporting. So in this work, what we were doing was a qualitative analysis of these free text survey comments on this specific question about whether or not the incidents were reporting and what happened. So it's situated in a realist ontology and interpretivist epistemology. We used qualitative description, as described by Sandalowski, as our methodology, and then followed the principles of inductive thematic analysis as our specific methods. In practical terms, that meant aggregating the survey comments and subjecting them to several rounds of open and focus coding using the runs. And the goal there was to identify and explicate social processes that the participants were described and use those social processes to develop an explanatory framework to better understand how organizational culture might be limiting reporting. And then broadly, we engaged in a number of processes to promote reflexivity and enhance trustworthiness in the data. These things are common to qualitative research and include memoing, situating our findings in an ongoing literature review, and consulting with people in the community to ensure the acceptability and transferability and validity of our findings. So what we found, starting at the top, was that the participants articulated to us that violence in the workplace is experienced as widespread and chronic. And so the quantitative portion of the survey bore this out, where the majority of the participants did report experiencing multiple different forms of violence, and some of the situations they described were, quite frankly, very shocking. But what they told us in the comments was that it is so widespread that it starts to fade into the background as just another chronic workplace stressor. And because of that, and because paramedics respond to uncontrolled situations that involve crises in the community, the perception is that being exposed to violence is simply unpreventable. We can't control the situations that we're called to. We can't control the behavior of the people that we interact with. And so we can't really do anything to meaningfully reduce the risk of violence or the experience of violence that we encounter in the course of our work. Because the majority of the situations of acts of violence were perpetrated by people for whom criminal prosecution was either unlikely or, in most cases, quite honestly inappropriate by way of mental health crisis, for example, or just generally stressful situations, there's this perception that there's no consequences for people who perpetrate acts of violence. And the end result of this is that the ability for paramedics to simply brush off and move on from violent encounters is then normalized as an expected professional competency. And where survey participants were telling us about situations where they did come forward and say that they were struggling after a violent incident, their suitability for paramedic work was questioned. So essentially we're saying it is so widespread and chronic, we can't stop violent behavior from happening. There aren't consequences for people who, for the most part, who will assault paramedics, that you just need to learn to deal with this. And if you can't, if you're bothered by these types of things, then maybe you should look at another form of work. Maybe this is just not where you need to be. So where we're going from here, our overarching goal is to start to change that organizational culture. Culture is a big beast. It's a big wheel to turn. And so we're taking small bites and nibbling at this over the course of several different components of work. But the big one that we've been spending a lot of time on is rethinking reporting. And so through an extensive stakeholder consultation and engagement process, we have since developed a new reporting process, in large part to try and challenge this idea that this may be something that is a part of the job, but that doesn't mean that it's an acceptable part of the job. You're not simply expected to tolerate this. And so with a lot of input from the community, we developed a new point of event reporting process, and we're using the data that we're gathering from this novel reporting process to start to generate prevalence estimates of how common this is, what risk factors exist in terms of what emergency calls are associated with an increased risk of reported violence, and whether the experience of violence differs across important demographic characteristics, and what health consequences result from incidents of reported violence in terms of physical health effects, physical injuries, and psychosocial health effects as well. We're using these data to move forward a collaborative, multi-site, prospective research study. And so if you're listening to this and you are with a paramedic service in Ontario and you're interested in collaborating as part of this research project, we would encourage you to get in touch. And we want to use this epidemiological profile that we're building to develop evidence-informed risk mitigation strategies that enhance paramedic safety, and also think creatively about how we respond to incidents of violence in the community, or how we respond to emergency calls in the community that may have violence resulting from them. So really quickly, here are the references. They're in the slides as well, and then there's a list of them here. And I am happy to talk more about this and answer questions.
Thank you so much for your presentation, Justin. I'm excited about so many parts of this talk you've just given this morning. I'm very excited, first of all, to see PSP themselves moving into research as you're doing. I think that's important for so many reasons, and your leadership is inspirational as you're doing that. So thank you. I'm also very excited to see what I'm sure is going to be a fantastic ongoing career for you with your innovations and applied solutions as you complete your PhD, move on to the next steps. I think it's important what you've showcased today, the incredible challenges facing our paramedics with respect to violence. And you've built such a nice set of solutions already, and you're building such a terrific ongoing solution with the pending study. So we've got some questions for our audience, starting with an attendee asking, how do you encourage paramedics to report incidents of violence that, as you mentioned, they are now right now supposed to simply consider to be part of the job?
That's a big question. That's really what we're grappling with, because we recognize that we're working uphill on that one. We're trying to overcome decades of entrenched organizational cultural features that do normalize this, that do position paramedics as being necessary to simply brush these off. What we're finding in terms of the reporting process that we've implemented in Peel, and we're now scaling up and rolling out to other services, which is very exciting, is that reporting hinges on the paramedics seeing value. It can't just be another form. It can't just be paperwork for paperwork's sake. It needs to lead to meaningful action that in some way addresses the problem, either in an immediate sense or on a bigger picture organizational level in terms of informing new policies and risk mitigation strategies. A lot of that is coming down to the follow-up the paramedics receive after completing a violent incident report. And so the process that we put together here is that each one of these reports gets reviewed and actioned by their leadership representatives. And then there's a specific list of actions that they can go through to follow up with the paramedic.
And so do you think that's part of building a more psychologically safe workspace for our paramedics to make sure that once we're done the first step of reporting, something gets done? Is that all part of that broader arc of continuum, if you will, towards mental health?
I really think so. I mean, I think, one of the presentations earlier, the keynote address on trauma and saying that it's perfectly normal to experience some adverse psychological reactions in the short term to traumatic experiences. But I think there's an opportunity for us at an organizational level to mitigate or reduce the adverse consequences that might come next. And I think what we do in those initial days following exposure to these types of incidents is going to be very influential. And certainly there's some qualitative research looking at critical incidents that bears that out. I think we can take lessons we're learning from this one very specific type of incident and apply those to other types of potentially traumatic or critical incident calls in the future as well.
Terrific, thank you. Emergency scenes can also be dangerous for paramedics, but they provide a really important and very necessary health service. How can we balance paramedic safety without compromising patient or community safety any more than we absolutely have to?
This is a really tricky question. It's one that we're thinking carefully about in the work that we're doing here in Peel Region. We do have some tools that are available to us to try and enhance paramedic safety. And so this includes, for example, delaying entering a scene that may potentially be dangerous and waiting for the situation to be secured by police officers, for example. But in thinking about this problem, I start to see that a lot of the violence that we are seeing is often the result of exacerbations of health and social inequities that create conditions that might manifest as violence against healthcare providers. And being on a bit of a soapbox, I would hate to see that as healthcare workers, as part of the public safety net, that our response to these situations is simply more policing or more restrictive or ways that might widen these health and social inequities. And so I think this is where our opportunity is to think creatively about this problem, because ultimately everybody wins when we enhance community safety, including us.
I couldn't agree with you more. Thank you so very much again, Justin, for such a terrific and important piece of work to help protect our paramedics who work so hard to protect all of us. I'm really excited to follow your next steps, and I look forward to hopefully working with you in the future, and good luck as you complete the last pieces of your PhD. Thank you for choosing to do this. We're now moving towards our close for our 2021 CIMVHR Forum PSP Session A. I want to again underscore and reiterate my gratitude to CIMVHR for allowing us to be part of their fantastic forum this year, and to congratulate all of our speakers on the outstanding research and knowledge translation efforts that they are engaged in, particularly today. I really do look forward to seeing the continued excellent growth in PSP research so that we can all participate in supporting ever better solutions to protect the mental health, safety, and well-being of all of our public safety personnel who work tirelessly to protect and serve all of us. I want to thank all of you very much for attending today and joining us in person. I want to remind you that you'll be able to review the content again online. And I sincerely hope to be able to join all of you in person again soon as we progress through the pandemic. My very best wishes to all of you. Please stay very safe. And thank you again for your participation and your engagement today. Take care.
So this brings CIMVHR Virtual Forum 2021 to an end. I hope all of you enjoyed the past 5 weeks of military, veteran, public safety personnel, and family health research presented in our 6 sessions. I encourage all of you to continue connecting and collaborating with colleagues from across the country and around the world. All of us working together is how we will truly advance research that will benefit those who are serving, have served, and their families. This year's forum would not have been possible without our sponsors. Thanks to their commitment to our military, veterans, public safety personnel, and their families, the forum was free of charge for all participants. To our platinum sponsors, Edgewood Health Network, True Patriot Love Foundation, and the Canadian Institute for Public Safety Research and Treatment, thank you. To our gold sponsors, Sunshine Coast Health Network, Canadian Cannabis Clinics, and the Journal of Military, Veteran, and Family Health, which I encourage all of you to submit your papers to, thank you. We are beyond grateful for your support. A reminder to all that you have until November 5th to connect with these dedicated organizations on the virtual platform and watch past sessions to receive your continuing professional development credits. Mr. Fardas Hosseini and Dr. Nicholas Carlton, thanks for wrapping up Virtual Forum with your professionalism and knowledge. All of us at CIMVHR appreciate your support. To all students and postdoctoral candidates, our Student and Postdoctoral Engagement Committee will be hosting a social event this evening from 6 to 7 p.m. Eastern Time. The registration link can be found in the spec booth. Finally, to the researchers who presented today, thank you for the time and effort in developing your presentations. I look forward to seeing the next steps of your research in the future. With that, I will say goodbye for now, and we'll really hope to see all of you in person for Forum 2022 in Halifax, Nova Scotia on October 17th to 19th. The Forum website will have 2022 details posted early in the new year. So for now, to you and your families, stay safe and be well. Thank you again.